AFib, we all know what it is. The actual atrium is fibrillating. The only reason why this gets brought up is because this is a pathophysiology, a big problem with hearts. When the atriums fibrillate, what happens is clots start to form within the atrium because atrial kick gets reduced. Now, I don't know if that's the first time you ever heard of a term atrial kick. Atrial kick is when your atrium contracts and pushes blood into the ventricles. But because my atrium is fibrillating and shaking, it reduces the amount of pressure that it's forcing blood into the ventricles. And because of that, some blood remains inside the atrium. Now, when blood remains inside an area and stays stagnant for too long, it starts to clot. This is why patients with atrial fibrillation need to take blood thinners. They need to take anticoagulants so they reduce the chance of them forming a clot within the atrium. Tachycardia. Why is my patient tachycardic? Is always the question, right? Were you watching Cops? Is it Shark Week? I don't know. But if you weren't, you shouldn't be tachycardic if you're watching TV. Do we intervene when it's tachycardia? Well, it depends on what's going on. Am I going to intervene just because I see tachycardia? No. I'm going to intervene if I see a tachycardia with a heart rate greater than 150. Why greater than 150? Because a decrease in cardiac output is a result of a patient with a heart rate greater than 150. It does not allow the heart to fill, the ventricles to fill with blood. If my heart beats so fast and it's not allowing that blood to fill into the ventricles with each contraction, then my cardiac output is going to be reduced. And if my cardiac output is going to be reduced, my patient is going to become unstable pretty damn soon. And eventually my patient is going to code. This is why we need to intervene when the patient's heart rate is too fast. Again, tachycardia just means above 100, but we're not going to technically intervene unless that heart rate is too fast. Now, are they stable or unstable? I don't care what you use to determine stable versus unstable. Just remember this. Hemodynamics plays a huge role in stable. If I run a call tomorrow on a patient that is 50 years old and they have chest pain and their heart rate's 160, they're not unstable to me. Okay, I need to figure out what's going on. Just because somebody tells me they have chest pain, I see chest pain patients all the time with fast heart rates. We call that anxiety, right? They get carpal pedal spasms, they're breathing super fast, their heart rate's extremely elevated, but as soon as that patient starts to relax, the chest pain goes away. Would I change the way I look at this patient though if my patient was altered? Or would I change the look of this patient if I see cardiac abnormalities on their 12 lead? Or would I change if my patient is hypotensive, cool and pale and showing signs of shock? Absolutely. Those are patients that are unstable. Those are patients that need to be treated. Okay. Those are patients that need further intervention. And we're going to get into stable versus unstable here, talking about treatment. Normotensive, or are they hypotensive? We talked anxious or altered mental status, right? That's going to kind of determine how am I going to treat this patient. If my patient is stable, hemodynamics is not a problem right now, which means my blood pressure is fine. Blood pressure looks good. My patient might be anxious, sure. But let's say that this is a cardiac problem. Let's say my patient's 92 years old and they have a heart rate of 172. And I'm determining, hey man, I'm going to go ahead and treat this. This person got woken up in the middle of the night. Their heart rate's now 172 or an SVT. I need to consider several things. Because it's SVT, if you remember what I talked about earlier with vagal maneuvers are going to affect the SA and AV node. If it's a sinus rhythm, it's coming from the SA node. Should a vagal maneuver affect the SA node? The answer is yes. So I'm going to perform a vagal maneuver. Ask my patient to vagal. If I do not see a change, I need to start an IV. We're going to start with fluids while I'm getting my medications ready. First medication that we're going to consider would be adenosine. Adenosine slows conduction through the AV node, right? Basically disrupting a re-entry SVT and hopefully bringing it back to its normal rhythm. If that doesn't work, I'm going to attempt it again. And if that doesn't work, then I'm going to consider cardioversion. Now, I know the algorithm states you can, if my patient remains stable after giving my second dose of adenosine, I can use another medication. If it's a sinus rhythm, I can use cardizem or diltiazem, or I can even consider something like amiodarone. If your protocols allow, you can even consider something like a beta blocker. Okay, it all depends on what medications you have and what you're going to use to treat. Talking a little bit about adenosine, I know there's a lot on the screen right now. Everything that's about adenosine is here. How much we're giving to adults, how much we're giving to pediatrics, what it does. If I say, what does it do? It slows conduction through the AV node and can interrupt reoccurrent or re-entry AV nodal pathways. If there's an SVT that is re-entry SVT, there's another pathway that was made around my AV node, and it's just constantly being re-entered between my AV node and back into the SA, and it causing my patient to become extremely tachycardic. Adenosine is an awesome medication that fixes that. Just real quick about pharmacology, you are expected to know all of this. I'm not going to tell you that you need to be able to recite it word for word, but not only do you need to understand how it works, what are my indications, what are my contraindication, and what are my doses for adult and pediatric. Everybody is expected to know that. All right, diltiazem, indicated for stable, narrow QRS tacks if the rhythm persists despite vagal maneuvers, or adenosine if the tachycardia is recurrent to control ventricular rates in patients with AFib or a flutter. So it's used for either. It's used if vagal maneuvers or adenosine did not work with a tachycardia, or it's also used to control ventricular rates with AFib or a flutter. Diltiazem is an awesome medication. Just remember, we give it slowly, and it's used for narrow complex tachycardias. Amiodarone, stable, regular narrow complex tachycardias if the rhythm persists despite vagal maneuvers, and adenosine, right? Just like with cardizem, to control a ventricular rate in stable, irregular, narrow complex tachycardias or cardiac arrest resulting in VFib or pulsus VTAC after CPR, defibrillation, and vasopressors were given, we can consider amiodarone. You have to know the algorithms. You have to know when we can use these medications and what they're used for.